Warm greeting to everyone. Last class we had discussed about the posterior hip dislocation. Today I am going to talk about hip dislocation that is anterior and central. So we'll start. So in anterior hip dislocation, this is actually a rare injury. If it has to happen, it can be either a road traffic accident or the legs are possibly abducted and externally rotated. So this may occur, it can occur from a fall from a tree and the foot gets stuck and it affects excessively or the road traffic accident as I mentioned. Clinically, the limb is in the attitude of external rotation and there may be true lengthening with the head palpable on the groin area. So if we can aim out anteriorly, you'll be able to feel the head in the groin area if you palpate. So the treatment and complication is almost similar to the posterior dislocation as I explained in the last class. So just listen here, this is the normal area, normal X-ray of the hip, which means if you are comparing the X-ray, I had told you in the last class, if you are comparing X-ray, you have to consider the normal part, that is this side, normal part, you have to compare first of all. So you will be able to see the hip is placed properly inside the acetabulum. This is acetabulum, hip is placed properly. But just see here, this is the affected area. Affected area. Okay. So here can you visualize or just can you able to see this is acetabulum and here you will be able to see the head of femur. Head of femur had came out of the acetabulum. So here you will be able to see a dislocation. So when you are comparing the X-ray, you have to just make sure first compare with the normal side. Sorry. Just compare with the normal side, then you will be able to easily distinguish what's the difference between the normal as well as affected side. So we'll talk about the clinical features right now. Mainly as like all the palpation or dislocation, there will be localized pain, stiffness and tenderness. Do you know why we are getting a localized pain, stiffness and tenderness? As you also might have studied in the second year, pain is an unpleasant stimulus which helps us to overcome or which will avoid the further injury. So if you are getting a localized pain or stiffness, it just indicates that we are not supposed to move from a particular area because as I told, if you are going for a forceful abduction then external rotation, this injury can occur. So this localized pain, stiffness and tenderness won't allow you to go further or which won't allow you to excessively or exacerbate the condition. And inability to bear weight will be there. See here, as the hip had came out from the femur had came out from the acetabulum, it won't allow you to go further or inability to bearing weight will be difficult. Then the next is the limb is accelerated with apparent lengthening. That can be because see the femur had come out from the acetabulum. If the femur had come out from the acetabulum, definitely the length of the limb will be more. Because if it is properly aligned, it will be like this as a normal side. So if it is not properly aligned, then what will happen is the limb will come out or the femur will come out of the acetabulum and the length will get increased. So now we'll discuss about the medical management of this condition. Manipulative reduction under general anesthesia can be given and we have to make sure immobilization in a hip spica or in a normal split for 6 to 8 weeks are done. Normal split you might have seen in your wards or when you get posting to the ward, you'll be able to see the hip spica. So open reduction may become necessary when the attempted reduction fails. If the closed reduction fails, then the doctors have to go ahead and have to do the open reduction. So now we discuss about central dislocation. This type of dislocation results from a fall on a greater trochanter or due to the road traffic accidents. The floor of acetabulum is fractured and head of femur is pushed into the pelvis. The same way, just compare the normal side and the affected side. So is the normal one, and this is the affected one. Alright? Same way, the hip came inside, pushed inside the pelvis of the left side. Right side is normal, left side is pushed inside the pelvis. Now we will talk about the clinical features of central dislocation. As mentioned, several local pain and stiffness will be there in order to prevent further injury. Hip abduction rotation is markedly restricted with severe pain. Severe pain will be there, along with the rotation will be restricted. Unattempted movement of the hip joint, especially when the hip abduction rotation is you are trying to, or if you are a patient trying to perform, it will be restricted. So body mass is palpable in rectal examination. If you examine the rectal area, the body mass will be palpable over that area. The limb remains in neutral rotation and it will be short. Can you just see this? Here the limb is short in length, but here the limb is elongated or lengthened in its size, because in angle dislocation the femur will be coming down. But in the opposite dislocation, the femur is just going inside the acetabulum. That's why here the limb is getting shortened. So here medical manual is the dislocation is reduced by the traction and pelvis compression or heavy skeletal traction in two directions, longitudinally along the line of the leg and laterally to the greater trochanter. After reduction, the traction is maintained for at least 6 to 8 weeks. So why the person have to maintain, or why the medical, as a physiotherapist, you have to ask them to maintain it for 6 to 8 weeks? It is just because we have done with the reduction. It will take some time to heal. So the healing time is 6 to 8 weeks. When we are maintaining this traction within 6 to 8 weeks, it will be able to heal. So after 8 weeks or 6 to 8 weeks, we will be able to mobilize the hip joint. So what will happen if you didn't mobilize hip joint? As you all know, when the joint is not mobilized, definitely the joint can go for stiffness, the muscle tendency can occur. Then it will be really difficult for a physical therapist or physiotherapist to treat the condition. So full weight bearing, however, is started after or in about 3 months after obtaining the radiographic evidence of consolidation of the acetabular floor. So as I discussed in the many of your conditions, first protocol will be price, protection, rise, ice, compression and elevation. The same way they are doing, they are protecting the area with the reduction of the hip, and rest is given for 6 to 8 weeks in order to get it healed. And ice and compression you can give when it's necessary. Ice will not reduce the pain. Compression can be given. See, compression is given here with pelvic compression. Then elevation. Elevation, if required, you can give. So this is the way we have to assign the patient. Same way we have protect the area. Compression can be given if needed. If the swelling is there, we can give compression. It is also elevated. So protection is given, rest is given for 6 to 8 weeks. After ice, if you want to give, if the pain is there. Then compression also is, if it is necessary, you can give. But elevation now we have to give to the patient. So this is the mechanism, whatever is happening inside the joint when you are giving compression towards the lateral side, towards the greater trochanter. So it will pull the area properly and it will align in its neutral position. So if you are keeping the particular bone or joint in its neutral position for several days or several weeks, like 6 to 8 weeks we are giving for the patient. If 6 to 8 weeks are given properly, then you will be able to, or you will be able to find a result like the healing will be done easily. If you are giving in a neutral position or if you are giving the patient in a rest with a comfortable range, it will get healed properly. So next we go to our main part, that is physiotherapy management. So during immobilization, it proceeds on the same line as described of the fracture of femoral leg. I had taken the fracture of femoral leg when you were offline, means when you were virtually in front of me. So as a part, in order to maintain the integrity or the tone of the muscle, what we have to give give a strong isometric exercise in order to maintain the tone. If you didn't give the isometrics, as you all know, the first muscle which will go for wasting will be quadriceps. Then we have to strengthen the gluteus maximus as well as antagonist agonist ratio. We have to start strengthening hamstring and hip flexor. But just make sure gluteus maximus and quadriceps you have to take care properly. Because as you all know, quadriceps is the first muscle which will go for the wasting, and gluteus maximus is the other muscle which will help to make your body alignment properly. It will help the hip extension so that it will be maintained. So if you are giving isometrics properly, it's like the tone will be maintained, and when the patient is going for a proper gait or gait pattern, if the patient is going, the alignment will be proper. The patient will be able to use his limb properly. The muscles won't get wasted. So that while when you are going for the movement part, after 8 weeks we are mobilizing the hip, that time it will be really easy for the patient to proceed further. In patient treated with skeletal traction, the small range movements can be started by 3 weeks. Within 3 weeks, the small range can be started. The care should be taken by performing the movements which predispose to the dislocation. Example, hip adduction. These are the main things you have noted down. Hip, hip adduction and the internal rotation with flexion in posterior dislocation. If a person had a posterior dislocation, hip adduction and internal rotation have been taken care of. That I have discussed in the last class. And here is the point: hip abduction, axial rotation in the anterior dislocation. So if you are focusing, or if the person is trying for hip abduction and axial rotation, there are more chances hip can dislocate more. So that should not happen. That you have to make sure that's your duty or our duty to tell the patient he or she is not supposed to abduct his hip, or even he or is not supposed to take it for axial rotation. So this is the isometrics of quadriceps, as you all know. Here we have to keep a bedsheet rod or even a pillow you can keep. Then you will ask the client to sit down like this. So if the person is abducting properly, the patient will be, or you will be able to visualize the isometrics of quadriceps. For checking it, just make sure you can keep the hands or his quadriceps. Then ask the client to press this bedsheet rod towards the bed, means inside or down. So just make sure you have to keep the hand before he is going to press it. Once he started pressing, you will be able to visualize the muscle is getting activated. So here comes the isometrics of gluteus maximus. For isometrics of gluteus maximus, either you can keep a bedsheet or towel underneath his heels and make sure the knee should be straight. Then ask the client to press it down. The heel, the patient has to press it down. As you all know, see, consider this as a area where this is a hip. So if the person is pressing down, what happens is the bend is not there. The person's hip will be coming backwards like this. So when you are lying on supine, if you press behind, the person's hip will come back. So which creates the extension movement. So this is the way you can give extension or isometrics for the gluteus maximus. And then during mobilization period, we can start rigorous exercise in order to initiate the hip movements and strengthen the dislocated hip. Just make sure we have to strengthen it, because this person or the client had been immobilized for 6 to 8 weeks. You may be able to know 6 to 8 weeks if the person didn't move his limb properly, the muscle will be going for wasting. So we have to start with a vigorous exercise over the hip as well as over the knee also we have to start, because according to rules, if a area is getting restricted, for example, if a person is having shoulder problem, we have to ask the client to start with the finger exercise as well as elbow exercises, in order to make sure the distal part and proximal part should be should not go for wasting. So we are also consider the distal and proximal part also. Knee mobilization became necessary in the patient treated with hip spica. You know, hip spica means from the hip till the ankle, the hip spica will be there. So knee movement will be restricted when the patient had treated with the hip spica. So we have to start early mobilization of the knee when the person is treated with the hip spica. So assisted straight leg raise should be initiated and exercise to regain the control of the hip joint. So first thing we are starting is knee range of motion, then assisted leg raise. So once the knee range is completed, we can able to ask the patient to see once isometrics of quadriceps is done. Then next thing what we have to do is knee mobilization. After that, we can ask the patient to go to the assisted straight leg raising. So that once we are starting assisted straight leg raising, this is one movement, or this is a movement which will help for the initial movement which is helping for the heel strike. If you are heel striking, first the person will be standing. So if you are giving assisted SLR, I am just telling you what is used for assisted SLR here. You are starting with assisted SLR, then we have a progress to SLR. So assisted SLR we are giving just because when you are going for the heel strike, this is the first movement which has to occur when a person is starting for a gait, heel strike, you all know. So for that, we are starting with the assisted straight leg raising, so that the muscles will get activated. And it should be initiated and emphasized to regain the control of the hip joint. Once the control hip movement are regained, ambulation can be initiated with enough assistance by 12 weeks. So this is like after once we have started the hip range of motion, then knee mobilization has been started. Once the knee mobilization is proper, we have started the assisted straight leg raising. Once you are done with that, then ambulation can be started with the assistance. Assistance you have to provide by 12 weeks. Then once the patient is perfectly alright, we can ask for the independent ambulation within 15 to 16 weeks. So just imagine we had started from 0 week, 6 to 8 weeks is the immobilization. After 8 weeks, we will be starting with the mobilization. But make sure this should be your time limit. So on your goals, it should be there. Within 15 to 16 weeks, the patient should be able to independently walk by himself. So for training that, these things are necessary. Strengthening of the hip joint, muscle in order for the gait training, as well as demobilization if the patient is treated with a hip spica, not to make sure immobilization part will be affecting the knee joint. So once we are done with that, we have to start the assisted SLR. As I told, it is a part of the gait cycle. Then once the patient is fine with the assisted SLR, you have to go to the SLR. Once SLR, everything is coming proper, SLR and gluteus maximus strengthening, adductor strengthening, then you have to work on the hip movements with the ambulation have been given with assistance. Once the assistance progresses, then we can ask the patient to go ahead with the independent walking within 15 to 16 weeks. And so this is the area where you have to cover, where once the hip is going for weakness, the treatment protocol has to be changed. Now last one, we discuss about the complication. So once if you are starting in the hip rehabilitation, there will be also some complication if you didn't take care of the hip properly. So first of all, it will be associated with acetabulum, or rarely the head of femur can be affected. Injuries to sciatic nerve, you know there are structures on nerve which is going near to the hip area. So sciatic nerve can get injured if you didn't take care of the client properly. And one other thing is avascular necrosis, which can occur near the head of femur area. It may eventually lead to degenerative arthritis, which can even lead to total hip replacement. And unreduced dislocation will occur, and all dislocation which cannot be reduced by closed method or even by the open pressure at times. So these are the complications you may have to think when you are just about to or before going to treat a patient. If you didn't take care of the patients properly, there are more chances in hip area these complications can occur, like injury to the sciatic nerve because the sciatic nerve is nearby the hip joint, and if you didn't treat properly, or if the movement didn't come in the proper direction, it can lead to arthritis of the hip joint, which will further, further will provoke, or it is needed for the patient to go to the THR, total hip replacement. And another one is an old dislocation which cannot be reduced by the closed method or even by the open reduction can lead to unreduced dislocation. So if you didn't take care of these things properly, then dislocation can occur in any moment. So as I told, also others of it can occur, which can lead to total hip replacement. So these are the complications. So hopefully you understood the class. Thank you so much.